quick recap of the epidemiology and a bit on diagnosis before we focus on the management aspects. And as usual, if you have any question, please feel free to interrupt me and seek any clarification. So in terms of the burden of TB, so roughly 1 million cases of childhood TB occur every year, and this makes up about 10% of the burden. And in high burden countries, for example, like Zambia, this could be just noted that in high burden countries, you can get as much as 15% of the total cases being pediatric cases. I'm getting a bit of feedback. Can we mute ourselves? Okay.
I've muted everyone.
Okay. So although it seems like a small proportion, 10% of the total TB, but when you look at the deaths, almost a quarter of the children with TB die from it compared to adults. And then most of these deaths occur in children who have HIV infection. The sad part is that majority of pediatric TB is undiagnosed and untreated because, first of all, because of access to diagnostics, and because most children do not access preventive services as well. And about 25,000 develop multiple drug-resistant TB. So in summary, basically, this is the whole 7.5 million get infected, 1 million develop TB, and a quarter of those die. And then if you look at this graphic down here, there's a very big case detection gap. So in children who are below under 5 years, you find that 69% of them are not detected compared to the others. And this chiefly comes because of the challenges of making a diagnosis in that age group. And then when we come to Zambia, so in 2017, it's estimated that there were about 62,000 people who fell ill with TB, but only 40,000 of them were diagnosed. So there's a case detection gap of almost about 20,000. And of these ones who were notified, so that almost 25, if you add this 25 and that 36, it will give you the 62,000. And there were 18,000 TB deaths. So if you look at that, that's on an annual basis. And if you look at COVID, I think we are just about 25 dates since the COVID started. But we get around 18,000 TB deaths every year. And then when you look at drug-resistant TB, it's estimated that almost 2,000 cases should have been diagnosed in 2017, but only 500 were diagnosed and detected. And even out of that 500, only half of them were reported to have been notified and started treatment. It means that half of them had MDR TB, but for one reason or another, then they never got into treatment and they were never notified. And when you look at the burden of TB in general, you find that the trend has been going down a little bit. The pediatric portion, and unfortunately, has been shrinking, not because there are fewer TB cases in that population, but mostly because of their an inability to detect the cases. And any child who is in contact with a known case of TB is supposed to go on preventive therapy. So if we're doing everything all right, 100% of the children who were in contact with TB should receive preventive therapy. But in 2017, only 4% of those received it. So if we go to diagnostic, I think this is the basic approach when you're diagnosing TB in a child. You look at risk of infection. Is there a risk of infection in this child? Does the child have symptoms suggestive of TB? And there are any radiological features that may suggest TB? And do you have mycobacterial conformation? So in terms of looking at the risk of infection, we establish that by establishing that there's a contact in the household. Has this child been in contact with anybody with TB? The other way of establishing that a child has TB infection is doing a tuberculin skin test. And if it's positive, then it tells you that the child is already carrying mycobacterium in the body. And then you do a clinical evaluation and establish that there are symptoms suggestive of TB. And the main symptoms is cough, fever, well lost nights, and reduced playfulness. And then you look at the radiological changes that may suggest TB. And then you do bacteriological confirmation either by ZN stain, gene expert, culture, and now you can also, we've added the urinary lamb to that confirmation. So in the absence of bacteriological confirmation, you make a diagnosis of TB based on the establishing that there's a risk of infection, okay, that there are symptoms, and there's a risk of infection, and there's a bacteriological confirmation, and there are X-ray abnormalities. So in the absence of bacteriological confirmation, you make a diagnosis in the presence of symptoms, risk of infection, and radiological changes. And pretty much 70% of your pediatric TB diagnosis is done without a bacteriological confirmation. Okay, so any questions on the diagnosis before I move on? Okay, let's move on to treatment. So before you really establish treatment, there are these general principles that govern TB treatment. And these principles apply to adults as well as pediatric patients. So the aim of the treatment really is that you need to cure the patient, you have to prevent a relapse, or you have to prevent death. You prevent development of drug resistance, reduce transmission, and minimize toxicity. And then the treatment is usually prolonged, what we call a short course, and it's use multiple drugs. It's called short course. The treatment is 6 months, but it's called short course, chiefly because in the past, treatment lasted up to 18 to 24 months. And with the discovery of rifampicin, that was shortened to 6 months. And then it's divided into two phases. You have the intensive phase of 2 months and then a continuation phase of 4 months. And then the treatment is supervised. It means that somebody has to supervise that and make sure that the patient is taking the medication. And then before you decide how you are going to treat the patient, these are the things that you need to put into consideration. You need to know what is the type of disease. And the type of disease can either be a severe form or it could be a non-severe form. So all lung disease, pleural disease, lymph node disease is considered non-severe forms of TB. Whereas things like TB meningitis, any form of disseminated TB and miliary TB and spinal TB are classified as severe forms of TB. And then the combination of the treatment that you are going to use is based on what your national program recommends. So in Zambia, all TB treatment is standard. You can't just decide that I'm going to treat my patient this way. And this is determined by the national TB program. And then for children, They are dosed according to the body weight, and we use fixed dose combination. These are pills that contain multiple drugs. And there are 4 drugs that we use for standard treatment. This is a treatment for patient who's been treated on the basis that they have drug susceptible TB. So we have the isoniazid, the rifampicin, the pyrazinamide, and the ethambutol. And these drugs act specifically on a specific part of the tuberculous mycobacterium. So for example, rifampicin prevents transcription, and then the aminoglycosides like amikacin that are used for second-line treatment prevent translation, whereas pyrazinamide acts on the cell membrane. And then pretty much most of the TB drugs act on the mycobacterial cell wall. So these things include like isoniazid. Ethionamide is used for treatment in second-line therapy. Then ethambutol. Thiacetazole is an old drug that was abandoned because it causes severe Stevens-Johnson reactions in patients who have HIV infection. So in case you forget where these things act, I think just remember where the rifampicin acts and the pyrazinamide acts and the aminoglycoside, because pretty much everything else acts on the cell wall. And then why do we need to combine these drugs? We combine them because each drug plays a specific role. So if we look at INH, so INH has early bactericidal activity and results in the rapid reduction in the organism burden. So when a patient who's smear positive starts taking their TB, they will convert usually within the first 2 weeks, they would have converted to negative. And this happens thanks to isoniazid in the regimen. So it reduces dramatically the amount of organisms that an individual has. And then the rifampicin has a sterilizing activity. It contributes to ensuring that any persisting organisms are treated. And it's the main drug that contributes to ensuring that the patient has a cure without relapsing. Then pyrazinamide is unique because it acts in acidic environments. So remember I think from a 5th year lecture, that usually the TB organisms are found in granulomas. And the granuloma, they look at the structure of the granuloma. It's really a very structure that is maybe tough for most drugs to penetrate and get to the center. So pyrazinamide has that unique activity that it is able to act in those environments, like in the granuloma. And it's therefore the one that also contributes significantly to ensuring that treatment is shortened. Then we have ethambutol, and ethambutol is really the add-on drug that is there to just add what you call drug pressure. I don't know whether there's a simple way I can explain it. It's an added drug that takes care of any other things that the other guys haven't taken care of. And it's therefore important in preventing development of resistance. And if you look at all the other 3 drugs, they are all bactericidal. It's the only bacteriostatic drug in the regimen. And why do we need this long duration? So the 6-month duration, this is a hypothetical model about the role that each one of these drugs play in this regimen. So this explains why we need an intensive phase and a continuation phase. So when an individual is infected with TB, it's hypothesized that there are 3 groups of organisms. There are those that are in this big blue circle here. On the y-axis is the number of organisms. On the x-axis is the number of months that you need of treatment. So this big A is composed of drugs that are called rapid multiplicators. I mean, the organisms that are rapid multiplicators, and they're usually the ones that are responsible for the severity of the disease. And then we have a smaller population made up of slow multiplicators and organisms that sit in acidic environments and in granulomas and cavities. And then you have these sporadic multiplications. These are organisms that have a tendency to undergo latency. So the rapid multiplicators form the biggest proportion of the population of the bacilli. So when you start treatment, the rapid multiplicators are usually effectively cleared by rifampicin, followed by INH, and to a smaller extent, ethambutol. Whereas the slow multiplicators in acidic environment are best dealt with by PZ, then followed by rifampicin, and to a smaller extent, INH. And then the sporadic multiplicators that have a tendency to undergo latency are best treated with rifampicin and INH. So you need within the first 2 months, by combining all these drugs, you would have significantly reduced the population of the rapid multiplicators because they are rapidly multiplicating, so they are therefore highly susceptible to drugs. And you've also reduced the ones that are occurring in acidic environments and hard to reach areas, so that by 2 months, you have pretty much cleared the large bulk of the organisms that an individual has. And therefore, you only remain with the organisms that have a tendency to undergo latency. And this may persist, and you may need the extra now 2 months with fewer drugs to clear them. And it's usually the reason why most TB patients, when they start treatment and you've given them intensive phase, by the end of the intensive phase, most of them are fine. They're okay, they have no symptoms. And that's when most of them decide to abandon treatment because they don't see the need. But because if they stopped treatment, this population of organisms that have a tendency to undergo latency will then start repopulating and will cause the patient to have a relapse. And that's the reason why you need that extra treatment to clear these organisms that have a tendency to undergo latency. And so for that reason, that's why the treatment is fashioned out like this. So you have the intensive phase and the continuation phase. In individuals who have severe disease, you need about 10 months for the continuation phase to clear everything out. And remember what I said, the most important, the decision on whether the patient will have a prolonged continuation phase is based on the disease severity. If they have non-severe disease, they get 2 months of 4 drugs and 4 months of continuation. If they have severe disease, they get the same 2 months and then 10 months of continuation. And this is the dosage. So it's about 10 milligrams per kilo, 15 for rifampicin, 35 for PZ and ethambutol. You need the 4 drugs. In the past, we used streptomycin, and it's no longer recommended for pediatric TB treatment. And then we need a longer treatment for severe forms. So the treatment is given using what's called a fixed dose combination. So they have fixed dose combination for children that contain 3 drugs. So you have rifampicin in these ratios, and then you have a 2 drug combination that we use in the continuation phase. So the 3 drug combination is what we commonly refer to as a 3-FDC. As a 2 drug combination, it's called a 2-FDC. Adults use a 4-FDC that contains ethambutol. But for the pediatric patient, we use a 3-FDC, and then we use ethambutol as a separate pill. The pediatric drugs are dispersible because, if a child is 5 months, they are 5 months, or they are 1 year old, they are not going to swallow pills. So we use dispersible tablets. So you have a tablet like that, then you get a bit of water and put the tablet in the water, and then it dissolves and makes a suspension, and therefore the child can take it without any problems. And this is how you decide how much drug to give. You weigh the child and determine which weight band they are falling. and based on the weight band that they are in, that will determine the number of pills of the 3-FTC that you give, the number of pills of the ethambutol, and the number of pills of the other drugs. And then those who weigh above 25 kilo are dosed using the adults, which uses a 4-FTC, which has 4 drugs. So just briefly, that in the past, ethambutol was not included in the pediatric TB treatment, but over the years, it's been shown that it's because there were worries that children may develop optic neuritis, but now it's been established that that's not a big risk; it's a negligible risk, and therefore the benefit of having it in the regimen outweigh the potential risk of them developing optic neuritis. So these are the common side effects of TB drugs. So rifampicin, PZ, and isoniazid, they all give you hepatitis. Okay. And can I ask which one of these is the most hepatotoxic? If you have a patient who comes who's on TB treatment and they present to you with jaundice and they have raised ALT and AST, which one of these drugs is the most likely cause?
Pyrazinamide.
Pyrazinamide.
Yeah, it's the pyrazinamide. Okay, and then followed by?
Rifampicin.
Any other offers?
Isoniazid.
Yeah, so it's the pyrazinamide followed by the INH, then the rifampicin. That's in terms of hepatotoxicity. That's whereas the ethambutol, streptomycin, I included it, although we don't use it anymore. It's not hepatotoxic, but it has renal issues. So okay. So these are the main. So hepatitis for the 3 of them. Rifampicin discolors of body fluids. Okay, and it can also give you GI problems. The commonest symptom of PZ, apart from the hepatitis, is it gives you joint pain. So it gives you a gouty-like condition. And INH is peripheral neuropathy, and the ethambutol is optic neuritis. But there are other less common. The ones that I've listed are really pretty much the commonest. Rifampicin also gives you a hematological toxicity. It can also give you renal toxicities as well. INH can precipitate an acute psychosis, I think especially in adults. Okay. But if you compare the rate of occurrence of toxicities in children compared to adults, you will find that adverse effects are very unusual in children. And when they occur, it's usually hepatitis, which is usually reversible by just withholding the drugs for a short while until the liver enzyme normalizes. Okay, so any questions on treatment before we go on to the next bit? On the drugs.
Good morning, Dr. Chabala.
Morning.
Yes, I just wanted to find out if there's any role for use of vitamin B supplement in the management.
Okay, yeah. So the vitamin B, which is usually recommended in all adults on TB medication, is chiefly included because of to counter the effects of INH peripheral neuropathy. And therefore, for pediatric patients, because INH-induced peripheral neuropathy is not very common in children, so for pediatric, we only say give B6 in children who are HIV infected and in children who have some degree of malnutrition, moderate or severe malnutrition, then it means that they will need additional B6. Okay, so HIV infected and children with severe malnutrition. Okay.
Okay, thank you very much.
Yeah. Any other question? The other thing I think I should have mentioned is the steroids. So the steroids are indicated in patients who have TB meningitis and those who have TB pericarditis. In some small children, they may present with TB where they have TB, which is manifesting as intrathoracic lymphadenopathy with very big lymph nodes in the hilar region, and sometimes those hilar lymph nodes may compress an airway. So if you establish that a child who you've diagnosed TB has an airway compression because of an enlarged lymph node, that's another indication for you to give that child steroids as well. Okay. Okay, so we move on to the next bit. So,
Dr. Chabala,
yeah.
there is a question in the chat box.
Oh, okay. So how do I see it? Delete the chat box.
So
How come
Bwalia is asking if
I can't see any chat?
pyrazinamide is most effective for persisters. Why is it not continued?
The most effective for persisters is rifampicin, isn't it?
Yes.
You see there? It's rifampicin and INH. The PZ we said was effective in organisms that are in hard, if I can call it hard to reach environments. So in cavities, in granulomas, that's where it is usually given. Does that make sense? And then the longer you give your pyrazinamide, the higher the chances of you causing hepatitis. So because most of these slow multiplicators that PZ is good for we expected the population is significantly reduced. We're therefore comfortable to continue with just rifampicin and INH in the continuation phase. Okay. Are there any question? Any other chat box questions?
Good morning,
I
Doctor.
can't see. I can't see any chat box. I don't know. Okay. Yes.
For pediatrics, how long do we expect the sputum to be negative after we've started the treatment?
Yeah, so the thing is that most pediatric patients have a low bacillary load. Okay, so for example, and how would you know that? You will find that if you do an adult smear, the report usually comes 3+, 4+, or something, but most pediatric patients, it will be 1+, scanty. Okay, so for that reason, they will seemingly clear, convert to smear negative once they start treatment within 2 weeks, most of them. In fact, some studies have been done where they did cultures of children who have TB, which was culture confirmed, and then they start treatment and they're obtaining cultures within the first few weeks. They actually have shown that most children in the first week of TB treatment, they would have reduced, most of them become culture negative. So they convert pretty fast compared to adults. Okay. Any other question? Okay, so let's move on. So when you're treating TB, chances are that you're going to be, this person with TB also has HIV. And in our environment, among adults, 50% of adults in Zambia who are treated with TB also have concomitant HIV infection. And if you look at the pediatric population, it's about 40% who also need. So chances are that when you have a TB patient in front of you, that patient is HIV infected as well. And therefore you will need, in addition to managing their TB, you will need to manage their HIV. And therefore the principles of TB treatment. The same principles that I mentioned earlier on, they are not different in any child who's HIV infected and HIV infected. It's the same drug combination, the same duration, same doses, same everything. Okay. And so what we usually then focus on is managing the issues that come with the HIV. So like I said, you use the same drug, same duration. You ensure that if the child is on HIV treatment, within the first 2 weeks of being diagnosed with TB, they should be started on ART. Okay, they should receive the comprehensive package of care for HIV, including cotrimoxazole prevention, pyridoxine supplementation, somebody asked already, and then they're more likely to be malnourished. Okay, and therefore they will need nutritional support, and they're also at increased risk of relapse and drug resistance, and therefore they need to be carefully monitored when they are on treatment. So the problem that comes mostly is the drug interactions between them and HIV drugs and the TB drugs. So do we know, can I ask questions about which common drug interactions that you're worried about when you are treating HIV and TB?
Rifampicin and DTG.
And?
DTG.
Yeah, so rifampicin reduces circulating level of dolutegravir. Any other interaction? Excuse me. It also reduces the circulating drug levels of lopinavir, ritonavir, or the PIs. Most the NNRTIs, nevirapine, and efavirenz, they are all reduced by the presence of rifampicin. Okay, so it reduces nevirapine, the PIs, dolutegravir, and actually TAF. TAF is the tenofovir-alafenamide, and therefore puts the patient who's on HIV treatment at risk of failure. Okay. Some of them, they have common side effects. So like hepatotoxicity, peripheral neuropathy is common to TB drugs and also common to HIV drugs. Okay. So what do you do when you have an HIV infected patient who needs TB treatment? How are you going to manage them? Chuma na bombe. Hello? I can't hear.
I was saying you can double the dose of the HIV drug like instead of doing
Okay, I can't hear what you're saying.
Can you hear me now?
Yes, I can now.
Yes. I was saying you can double the dose. For example, if there was of the HIV drug like dolutegravir.
Okay.
Yes.
If a patient is on dolutegravir, you double the dose. Anything else?
I'm not sure about the other thing.
Okay, anybody else sure? Kwalela.
Yes, okay, I'm not sure.
Mavuto piri. There are three technos. There are these three technos.
I was thinking you can also add the vitamin B6 because
B6.
of the multiple drugs that can cause peripheral neuropathy, and as well as monitor for the liver enzymes because of the chances of hepatotoxicity.
Okay, so you monitor toxicity well. You put you make sure you are giving B6 and all the other measures. Okay, so like I don't know who said something. So for one of the things is that you can use efavirenz because the efavirenz-based regimens have lesser interaction with rifampicin. Okay, but then there's the efavirenz you can contraindicate it in certain age groups of children. Okay, most of the children receive lopinavir, ritonavir as part of their ART. And therefore you add additional ritonavir to convert the lopinavir, ritonavir ratio from 4:1 to 1:1. So this is what is called super boosting. I think the lady already mentioned that if a child is in dolutegravir, you double dose. So the dolutegravir, you take it once a day, you change it twice a day for the duration of the TB treatment. If the patient is on TAF, you also double dose the TAF. Instead of giving once daily TAF, you give it twice daily. The other alternative is that you use a combination that has only nucleoside reverse transcriptase inhibitors, so AZT3DC and ABC. The problem is that this regimen is usually associated with long-time virological failure, and therefore it's not advised. The other alternative is that you just take out the rifampicin and replace it with rifabutin. But then this is not currently on the Zambian TB guideline because the TB drugs that we use come with as a fixed dose combination. So for first line treatment, we're usually not adopting it unless in patients who are on a third line HIV treatment and they need rifampicin replaced. Those are the ones that this option is availed to. Okay. Is there a question?
No.
Okay. So according to the Zambian guideline, this is how you treat any child who is TB HIV co-infected. If a child is less than 20 kilo and they have TB, you use abacavir 3TC with raltegravir double dose, or you use a combination of ABC 3TC and AZT. Okay, the alternative is to use efavirenz. If a child is between 20 kilo to 29 kilo, you use dolutegravir. If a child is above 30 kilo, you use again dolutegravir, but you are using a tenofovir-based combination. Okay. So this is how the Zambian guidelines currently advise that we do. Okay. And we have overlapping toxicities. I think we've already discussed it. So if you look at the antiretroviral drugs and anti-TB drugs, hepatitis is common between nevirapine and protease inhibitors, and these TB drugs here, rash is common with efavirenz, abacavir, nevirapine, then also can occur rifampicin. The quinolones and the ethionamide, these ones that we haven't discussed, they are part of MDR-TB regimens, so we'll touch briefly on them. And then anemia, neutropenia, AZT can cause that, but rifampicin and INH can also do. Nausea and vomiting is common to these, it's also common to these drugs. Peripheral neuropathy, stavudine, we don't use it anymore, and didanoside, we don't use it anymore, but it's common with these TB drugs. And then CNS problems for HIV drugs is mostly efavirenz, but it can occur with streptomycin, INH, cyclosporine, and actually isoniazid. It can give you acute psychosis. Okay. Any more questions on HIV before we move on to drug resistance?
Good morning, Dr. Chabala.
Yeah.
Yes, I also need to find out. So, in patients who have HIV co-infection with TB, when do you start the ATT and when do you start the HIV drugs?
Okay, so if you check it, so if a patient, so there are two scenarios, isn't it? The patient comes to you and you find them with TB, And while you're evaluating them for TB, you find they have HIV and they are not on treatment. Okay? So in that case, you will start the TB immediately. And then after 2 to 8, you evaluate them after about 2 to 8 weeks. If there are no issues, the patient is getting stable on TB drugs, they are not having severe nausea and vomiting, then you introduce the HIV drugs. You start them on ART, and your decision on which drug you use will be guided by this, okay, what is recommended. Depending on the child's weight, you decide which regimen you give, okay? The second scenario is a patient is already on ART, okay? And then you diagnose them with TB. So they are already receiving TB. They're already receiving antiretroviral drugs. So in that case, you will add the TB treatment to the HIV treatment. Then you look at the ART, which ARTs are they receiving? And is there any ARTs that you're worried about? So if they are on dolutegravir, you double dose it, okay? If they are on another regimen, for example, if they are on abacavir, 3TC, and lopinavir, you have to super boost the lopinavir. If you can't, you change them to one of these other regimens. Does that make sense? So already established on treatment, you modify the HIV treatment because you look at which drugs are going to have your problems with, and then modify those. If not on treatment, start the TB drugs, then within 2 weeks, start HIV. Okay? Is that clear?
Yes.
Okay, so let's move on to drug resistance TB. So, drugs resistant, first of all, you have to understand the different definitions of drug resistance. There's what we call monoresistance. That is when you only have resistance to a single agent. Okay, so if you only have rifampicin resistance, then you're monoresistant. Okay, before I describe polyresistant, let me describe what multiple drug resistance means. So multiple drug resistance means that you have resistance that includes both INH and rifampicin. Okay, so you may have resistance to ethambutol, and then you have resistance to rifampicin and INH, then you are said to have multiple, because remember, these are the two most important drugs in the regimen for the treatment of drugs associated for TB is rifampicin and INH, because they are used in the intensive phase and the continuation phase. So when a patient develops resistance to both of these agents, then they automatically have what is called multiple drug resistance TB. Okay, the patient may have other combinations of resistance, but as long as both INH and rifampicin are not there, then you call it polyresistance. So this is a patient who has resistance to PZ, they have resistance to ethambutol, but they only have resistance to INH and not rifampicin, or they may have resistance to rifampicin but not INH. So in that case, you call it as polyresistant. And then you have XDR, which is extensively drug resistance. Extensively drug resistant means that the patient has MDR TB, means that they have both INH, at least both an INH and rifampicin resistant, and then they have resistance to fluoroquinolones and injectables, which are used for second-line treatment. Then they'll be described as having multiple drug. And then when they only have rifampicin resistance, which you usually detect when you do the gene expert test, then you just call it rifampicin resistance. Okay, so we'll start talking about multiple drug resistance, TB. So like I said, there should be at least INH and rifampicin resistance. And how do you diagnose or decide that a child has MDR TB? So you start a child on multiple drug resistant TB when you have a confirmed MDR case. You've done a culture for TB and you've done a drug susceptibility test, and the report comes back to you to say the patient has rifampicin INH resistance plus other things, plus or minus other things, then that's a confirmed case. The other time you start a patient on the drug resistance regimen is if a patient who you are testing using the expert test and it comes back to you and saying they have rifampicin resistance. So they don't have multiple drug resistance by definition, but the presence of rifampicin resistance is an indication to start a patient on a multiple drug resistant regimen. Okay, a patient who is smear positive, but they have a confirmed MDR-TB case. Okay, or a patient who you have clinically diagnosed, for example, a child who is living with a mother who has MDR-TB, and you've decided that this child, based on abnormal X-ray and everything, they have TB, then you will manage them as MDR because they have a confirmed MDR contact. And then you can make a probable diagnosis if the child has TB with unconfirmed DST, but they are not responding to standard therapy and they are a non-contact of an MDR-TB case. Okay. Then, so how do you treat? There are two regimens. There's what is called a shorter regimen, and then there is what is called an individualized regimen. Okay. Just remember that the most effective TB drugs are the drugs that you use for first-line treatment. The agents that you use for second-line treatment, they're usually more toxic, they are less potent, the treatment takes longer, they are more expensive, and they are less evidence-based. So the shorter regimen, which is currently recommended in Zambia, lasts between 9 to 11 months. Okay. Whereas the individualized regimen, which is a regimen that we were using for so many years, but now it's slowly getting replaced by this, lasts up to 20 months. So you will see the combination. This is an intensive care phase, and you can see the number of drugs that you're using. Okay, so this is kanamycin, moxifloxacin, ethionamide, clofazimine. So it's a combination of multiple drugs, and then you have a continuation phase for that. Okay. The shorter regimen has advantages, it's lower cost, less side effects, better adherence, and has a better treatment outcomes. While the longer regimen has multiple costs, it's more costly, more adverse events, has challenges with adherence, has poor outcomes. But then how do you decide which patient gets which regimen? Okay. So according to the current recommendation, patients who have rifampicin resistance or who have MDR, who were not previously treated with a second-line drug, so they never used fluoroquinolones as part of TB treatment before, or they never used injectables as part of TB treatment. Okay. And patients in whom you've excluded fluoroquinolone resistance and resistance to injectables. And this is a decision-making, algorithm. So you have this criteria, you check, you make sure that the patient doesn't have any of these. So if the patient is pregnant, if they have extrapulmonary TB, then they don't qualify for a shorter regimen. You treat them with a longer or conventional regimen. If the patient doesn't have any of these, then they qualify to get a shorter regimen. Okay. And these are the groups of drugs that you use in second-line treatment. So you'll see for the first-line treatment, we only have simple 4 drugs. For second-line, it's a whole collection of different agents. So you have the fluoroquinolones and the injectables. So like I said, for standard TB, rifampicin and INH are the backbone. For drug-resistant TB, the backbone is the fluoroquinolones and the injectable drugs. So you will notice that you can use any one of these agents. That doesn't mean that you use all of them. So you will pick one here, 1 or 2 here, then you use 2 here, then you can use one of these. Okay. And if you look at the list of problems that you can have, this list of side effects with second-line drugs is long. And each agent has multiple problems that the patient will will have. Okay. Okay. So, any questions on drug resistance before we can move on to the next and last bit?
Yes. Good morning, Dr. Chabala.
Morning.
A question: if a patient defaults, what's the direction to take? And
So,
also on the hepatotoxicity of the TB drugs, how do you move when someone gets this hepatotoxicity from the drugs?
so if they have a drug-resistant TB, what is advised? I mean, if they relapse, what is the interrupted treatment? Is that what you said? Your question
Yes,
was on it.
interrupted treatment.
So for treatment interruption, you ask, has the patient, you first to determine which phase of treatment they are on. So they are in the intensive phase. You then find out, is this interruption less than 2 weeks or more than 2 weeks? Okay, if it's less than 2 weeks in the intensive phase, then you just continue where they left off, and then you calculate the total number of doses missed, and then you add it, you extend the intensive phase by the total number of days missed. Okay, so if the patient missed 7 days in the intensive phase, and then they show up, okay, so you just continue, but you add these 7 days to the end of the intensive phase. If they missed for more than 2 weeks in the intensive phase, you just stop the treatment and start again. Okay. For the continuation phase, it's 2 months. If they missed less than 2 months, you continue where they left off, add the number of doses missed at the end of the continuation phase. If this interruption was for more than 2 months, you start the treatment and restart from the intensive phase. Does that make sense?
Yes, it does. Thank you.
And what was your other question again?
Those who develop hepatotoxicity from
Yeah,
the
so
drug.
hepatotoxicity. So when you get hepatotoxicity, you stop everything. Okay? Then you monitor the liver enzymes, and when they return to normal, you then resume the treatment using starting with your list, the drugs that are likely to have the least hepatotoxicity. So you start with a Thambutol, you give it for 3 days, and the patient is not having recurrence of jaundice. You then move on to rifampicin for 3 days. Then nothing, you then add on the INH, and then finally you add the PZ and you have a complete regimen. That assumes that you have them as individual drugs, but in our situation, we don't usually have them as individual drugs. They come as fixed dose combination in one pill. So we usually suspend everything, and then we then wait for the liver enzyme to normalize, and when they are normalized, we then resume the treatment. And if they have a recurrency, we then remove the drug that we think is most likely hepatotoxic, and this is PZ. In this case, we will remove the PZ and replace it with a fluoroquinolone, which is usually levofloxacin or moxifloxacin. Does that make sense?
Thank you. Thank you.
Yeah. Okay, so we go to preventive therapy. So pediatric TB is preventable. Okay. When a child has been diagnosed with TB, it means that's a failure of TB prevention, because we know that most children will get TB because they have been in contact with an adult who has TB. And therefore, what's supposed to happen is that when we identify an adult who has TB, their treatment is not the end of the story. Okay, it's not, oh, you have TB, take the drugs, you know. Then the next thing we need to know is, are you living with any children in your house? Okay, and if the answer is yes, we need then to have those children evaluated for TB. And if the child any of those children are found to have TB, then they automatically start TB treatment. If the children have been evaluated and they are established not to have TB, then depending on the age of the child, you're supposed to put that child on preventive therapy. Okay, so this is what I'm saying, that if you have a child with TB, it's usually most of the time a failure to prevent TB. And usually what happens, for example, here at UTH, adults are seen in chest clinic, and when they are diagnosed with TB drugs, okay, go and take. And there's usually no linkage to see, do you have children, you know, all those things. So that's the challenge. Okay, so like I said, any child who has TB develops it because they've been exposed by an adult, okay? And TB preventive therapy actually stops the child who has an infection from having active disease, okay? The other aspect of prevention is making sure that you've identified all the TB cases. Okay, infection prevention is what you do when you have an adult who has TB and you want, it's the same thing like we're doing for COVID. When you identify a patient with COVID, you're taking measures to stop them from spreading. That's what we are supposed to do for TB as well. So if an adult who has TB, they should wear a mask, sleep in a room alone, practice cough etiquette. When they come into the hospital, when they are waiting in the queue, they are supposed to sit in a separate queue and wear a mask. Okay. So these are the main ways to prevent TB. The first one is the BCG, which is given at birth. It doesn't give you full protection against TB, because otherwise we wouldn't have pediatric TB if it was a 100% effective drug. But it does prevent severe forms. So children who are BCG vaccinated are less likely to develop TB meningitis, miliary TB, and spinal TB compared to the ones that are not vaccinated. The other way we prevent TB is what I talked about, is assessment of children who are in contact with any smear positive adult. And then the other area is the HIV group. We know that patients who have HIV are highly susceptible to TB. So we use what is called a 3I approach. So any patient who's HIV infected, we should do what is called intensified care finding. So in most HIV clinics in Zambia, at every visit that a patient with HIV goes for, there's what is called a TB screening form. So at each visit that a patient comes, they're asked TB questions. Are you coughing? And do you have night sweats and all that? Okay. So that if they have any of these, they're immediately screened for TB. Okay. The other way is that patients who have HIV and have been screened for TB and they are found not to have TB should receive at least one course of INH. So when they do the TB screens, the patient then is given INH if the patient has not received INH in the past. And then the other one is infection prevention, which I talked about. Every time that in HIV clinics, and a patient who shows up with cough, they are then given a mask and separated from everybody, and they are seen immediately. Okay, by far the most effective way of preventing TB is to identify and adequately treat adults with TB infection. So this is what the National TB Program recommends we do when a child has been exposed to TB. So is a child above 5 years or is a child under 5? If they are under 5 and we've checked and we've established they don't have any symptoms, then we give them the preventive therapy. Okay. If they have any symptom, morning, man. I'm fine and how are you? Oh, sorry for that. Okay, let's continue. And then if they found with TB, they are treated. If the TB is excluded, they get a preventive therapy. For those who are above 5 years, when they are symptomatic, they get treated for TB, they get evaluated for TB. If they are well, they are just monitored. So the INH is indicated for those asymptomatic under 5s of smear positive contacts. And you give it for 6 months, okay? So asymptomatic under 5 contacts. Those with HIV infection, those who are between 0 and 10 years, okay, they get it, okay, regardless of their age. And then the course of INH is 6 months, okay? So usually the ones that have been recommended in the past is INH for 6 months, okay? Yes, it's 6 to 9 months, for 6 months usually. But last year, in 2019, the Ministry of Health introduced other options. So mostly we have been using this option here. But now they've introduced this option that you can give either daily rifampicin alone for 3 to 4 months, or INH with rifampicin for 3 to 4 months, or what is called, you use a combination of rifampicin and INH, and you only give a weekly dose for 3 months. This one is not yet available. So the patients are not receiving it because the drug is not available. So by and large, you use these 3 options. Okay, because most HIV infected patients who need preventive therapy will be on ART and they will have issues with the rifampicin. So for HIV infected patients, the one that is recommended is the INH alone. Okay. Okay, so any questions? I think we've overshot our time. But do we have any questions?
Dr. Chabala, most of the drugs are available as fixed dose combinations. So in the case of HIV, where we are saying we should double the dose, or in the case where we want to give prophylaxis, how do we go about that?
So the double the dose is applicable to which agents, for example? So because remember the TB treatment or prevention doesn't change because you have HIV, isn't it?
Oh, yes.
Mm-hmm. So the double the dose, if the patient is on HIV, you will double the dose of the HIV medication. So if the patient is on dolutegravir, you double the dose. Currently, dolutegravir comes as a separate drug. I don't think it's available as a fixed dose combination yet. And in any case, for HIV drugs, the patient is on a fixed dose combination, then the patient should then be changed to single formulations so that you can enable you to make adjustment to the double dose. INH alone is available for prophylaxis. Okay.
Thank you.
Yeah. Any other questions? Okay, so I take it that all is well then. So as usual, I will share the slides.
Dr. Chabala, I haven't received the other two.
No, I sent it to you.
I don't think I received it.
Wait a minute. Unless I wrote, unless it went to, because I didn't get a bouncing mail thing. You know, let me check.
Maybe I could just follow it up.
Sina at Gmail.
Maybe I can send you the email once again, and then we can work from there.
Because look, if I show you my email box, it showed I sent it to you on the 24th. So unless I didn't do your email correctly, but it's vishusina, isn't it, at gmail.com. So just